Hello, everyone. Hope you are enjoying the session so far of this wonderful Congress. And welcome to our second set of simultaneous sessions. This is the community track, Pyruvate Kinase Deficiency Diagnosis and Management. And we have two wonderful speakers for you today, who will be introduced by our moderator, Mr. Carl Lander. My name is Dapo. I'll be the technical guide to make sure everything goes smoothly in this session. So I will first introduce our moderator, and then he will introduce our first speaker. So Carl is a registered nurse who lives with pyruvate kinase deficiency, one of the inherited metabolic disorders. He has spent a career in the National Health Service across a range of disciplines and roles and has experienced a wealth of his own and others' lived experiences. Carl is co-chair of MSUK and research director of the Pyruvate Kinase Deficiency International Alliance, based in the USA. He spends much of his time advocating for better care for those with PK deficiency, and as a long-standing Peak Registry Steering Committee member, he has co-authored several papers discussing the impacts of this disorder. Carl is currently undertaking a PhD in business management centered upon value-based healthcare, something that he is passionate about, helping to bring patient-centered care to the healthcare system. So thank you so much for being with us today, Carl, and I'll hand it over to you.
Thank you very much. It's a total pleasure to be here this afternoon, and thank you to all of our guests who have joined us. First of all, I'll introduce Dr. Tamara Schryver, who is a good friend of mine and a fellow board member of the PKD International Alliance. Tamara is a registered dietitian with a doctoral degree in nutrition science, and she minored in biochemistry and stats with a focus on public health. Dr. Schryver worked as a nutrition scientist in food companies developing healthy foods, which is a great passion of Tamara's, and that's what we'll be hearing about today. And she has been published in lay magazines and scientific literature. Tamara, I'm very much looking forward to your talk today, and let's see what greatness and wonders you've got to tell us about nutrition and PK deficiency and other anemias. Thank you.
Thank you very much. I'm so excited to be invited as a member to the Third International Congress. Thank you very much to Gansett for that. Let's begin. So today I'm going to talk about diet plans from ketosis to vegetarianism. As mentioned, I'm a dietitian and co-founder of PKDIA. These are my disclosures. I'm going to fly through this presentation to make time for everybody else. So today we're going to talk about PK deficiency, the symptoms and comorbidities, the basic PKD nutrient recommendations, and then the difference between a diet versus dietary plans. And we'll talk about beneficial dietary plans for people with PKD, and then non-beneficial dietary plans. And then I'll leave you with some final recommendations. You can find more detailed information on nutrition in this publication, Nutrition in Thalassemia and Pyruvate Kinase Deficiency, which is co-published with TIFF, and it's located on www.pkd.org. So first of all, we're going to talk about the PKD deficiency symptoms and comorbidities. I've got these listed on the left, and on the top half of this slide are those that are impacted by diet quality, and then on the bottom half of this slide are those that are require a lot more nutrition support and a nutrition team to a nutrition/medical team. And we're not going to talk about those today in this presentation. I'm going to talk about just the fact that we have anemia and the nutrients that help people with anemia, the fact that the impact of iron overload and regular blood transfusions, bone fractures, osteopenia, osteoporosis, pulmonary hypertension, and atrial flutter. And then the sort of diet plan that can help with more morbidity and mortality, and then different endocrinopathies. And really, I just want to let you know that we're going to focus on diet or prevention, so more of a prevention rather than treatment, because again, treatment requires a comprehensive team, and that really requires a visit to a dietitian and a medical team. So as I mentioned, there's a book that you can refer to for more details. But if you do have PKD, the nutrients and foods to encourage are the correct energy intake. So that's the correct energy that, or calories, energy and calories are kind of terms that dietitians intermingle. And that's the amount of energy to encourage growth. If you're an infant or child or teenager, or maintain your weight if you're at the ideal weight. Adequate, good quality protein. And I know there's been a lot of debate about what good quality protein is in terms of plant-based proteins, but if you get a variety of plant-based proteins in a day, that is actually considered good quality protein. And that amount that people with PKD and most people need is about 0.8 grams per kilogram body weight. Adequate hydration, which is 2 to 3 liters of hydration a day, 25 to 38 grams of fiber a day. That's for adults, it's a little bit less than children. Folate from food, which is green leafy foods generally. Folic acid supplements we do recommend and generally doctors prescribe for patients. Vitamin C containing foods. And I know a lot of people with PKD avoid vitamin C, but there's been research that actually indicates that people with PKD are short in vitamin C. So don't take supplements, but do eat vitamin C containing foods. And then vitamin D containing foods are encouraged along with supplements. Our diet rich in calcium containing foods like milk, dairy, yogurt. Diets rich in vitamin E containing foods, which are oils. Zinc, magnesium, and selenium, which are a lot of times found in dairy and meat products. So on the flip side, nutrients that we want to limit or manage are obviously iron-containing foods, which are generally found in red meat, saturated fat, generally found again in meat and or cheeses, trans fat, which is found in red meat-containing foods and snacks like chips and crackers, processed foods, sodium, which is all throughout the processed food spectrum, and then foods with excess added sugar, energy drinks. Energy drinks have a lot of nutrients, or I would call them nutrients actually, like guarana, caffeine, excessive amounts of caffeine that we just don't know how they interact with people who have PKD with their body types, and especially if you have atrial flutter. Excessive caffeine intake, again, that can affect people with PKD with atrial flutter. And alcohol. We really recommend no more than 2 drinks a day for men, 1 drink a day for women. And if you have liver disease, the recommendation is to avoid alcohol. So we're going to talk about the difference between diet and dietary plans. I'm not talking about diets today, which are things that are things to lose weight. What I'm talking about is a way of eating. So an eating plan that um, is adequate, it's balanced, it recognizes the individual variations, and you'll see that as we talk about these different diets, such as age, stage of development, taste preferences, and food habits. What's important is that they meet all the energy and nutrient requirements of each person at their individual stage of development. Some of the examples we're going to talk about today are My Plate, the DASH diet, plant-based dietary plans, which are kind of hard to talk about because there's so many vegetarians and vegans that don't actually follow a healthy diet. So we're going to talk about what is a healthy plant-based diet, the Mediterranean diet and Indo-Mediterranean diet plan, Japanese diet plan, Mind diet, and ketogenic diets. All of these diets have been researched using peer-reviewed literature that backs them up or maybe doesn't back them up, and we're going to talk about all of them today. So the principles of a dietary plan are a healthy dietary plan, I should say, is that they include a wide variety of foods and they include complex carbohydrates and fiber. So, in other words, they don't eliminate fiber, which has been a trend in the past. And they focus on correct portion sizes. I know people will say, well, pasta makes me fat, but if you include the correct portion size and focus on whole grain foods, that tends to not really be the case. It's a foods first approach and uses supplements only when there's deficits in nutrients in the diet. And it provides foods in a cultural context, which you'll see with some of the examples I've chosen. And then you balance the dietary plan and exercise levels to achieve and maintain an appropriate body weight. So here are some of the beneficial dietary plans that somebody with PKD could choose. They all have some sort of benefit, and we'll talk about those. So MyPlate, this is one of the most popular ones in the United States. It's developed by the U.S. Dietary Guidelines. It contains whole grains, fruits, vegetables, dairy, meat. The thing that's a little bit different is the serving sizes are based on household measures and not necessarily what's on the food package, but it's super easy to access. All the information that you need for MyPlate is on the website, myplate.gov, and you can make a customizable plan for yourself or your child based on your height, weight, age, stage of life, and your activity level, and it'll spit out a plan specifically just for you. What's also nice about it is this plan has an app, and it also you can connect it to your Alexa. It's got recipes, so it's super easy to use, and it's beneficial for just basically all-cause mortality or extending life. The Mediterranean dietary plan is probably my favorite dietary plan. It's the easiest to follow, which has been demonstrated in research. It's beneficial for heart disease, type 2 diabetes, brain health, cancer, all-cause mortality, and rheumatoid arthritis pain. It emphasizes fruits, vegetables, whole grains, but what really is known for is its olive oil, nuts, seeds, fish and poultry, and the use of herbs and spices instead of salt. And what I like also about it is it emphasizes social connections. And it just has a really, to me, a really great flavor. Similar to the Mediterranean diet plan is the Indo-Mediterranean diet plan. This doesn't have as much research. It's sort of an emerging dietary plan, but its spin is that it's more focused on the Indo-Mediterranean areas, Southeast Asia, and it focuses on tofu and soy proteins, fish and seafood for the protein portion, and the grains are more millet and barley. It does contain a lot of omega-3 fatty acids and saturated cooking oils and spicy condiments that really give its flavor, like soy sauce, fermented fish sauce, and fermented vegetables. It's rich in green and red tea, and as we know, tea helps inhibit iron absorption. It's low in sweets, and it is also part of that dietary plan is the social connections and eating with family and friends. The Japanese dietary plan, and we're not talking about the westernized Japanese dietary plan, but more the traditional plan, is minimally processed and it uses small side dishes, several of them. It's rich in steamed rice, noodles, fish, tofu, natto, seaweed. Pickled fruits and vegetables have a lot of fermentation, which is very healthy for gut health. It's rich in root vegetables, green and yellow vegetables, and it has been proven to be beneficial for heart longevity and type 2 diabetes. Also high in tea, which is inhibitor of iron iron absorption. The one to watch out for this diet is that it can be high in sodium content, so choose low sodium condiments if you choose to follow this dietary plan. Now, plant-based dietary plans or vegetarian vegan plans, the one thing that I would emphasize is that I have seen people that are vegetarians eat only macaroni and cheese, and that's not what we're talking about. We're talking about a varied plant-based diet that includes whole foods, not the plant-based meat alternatives. So there's a lot of emphasis in research on the fact that it's not a processed dietary, it's not a processed plant-based meat alternative, which you can see lots of those foods in the grocery store. It really is based on nuts, seeds, avocados, soy protein, tofu is fine, but not those processed foods. Those will help give the benefits, and also beans and seeds for protein. So it's beneficial for cancer, heart disease, hypertension, diabetes. There are some watch outs for vegetarian vegans if you're adolescents, children, or adults. Mostly that vitamin D, calcium, and B12 can be low in the diet. So you need to target foods that contain those nutrients, or else take supplements. The DASH diet is super beneficial for hypertension. It is a little difficult to follow. It has a restriction of 1,500 to 2,300 milligrams of sodium a day. Um, I'm not going to go over the details of it, but it is very beneficial for hypertension. So if you have pulmonary hypertension, this would be an appropriate diet to follow along with the medication prescribed by your physician. And then the mind diet. I bring this up because it is becoming increasingly popular for potentially, helping brain health. And there's a lot on social media about this promoting or preventing cognitive and dementia decline. The research is just not there yet for that. It is, however, a healthy diet, and it really focuses on a lot of berries and a lot of nuts. So 5 cups of berries a week. If you would choose to follow this diet, it would be fine. It would be perfectly healthy for a person with PKD, but it is not at this point going to stop dementia or Alzheimer's. And I think that's really important to know that that's where the research is on this diet. So, diets to avoid. One diet, if or one area that is really contentious for people with PKD is ketogenic diets. And that is because, first of all, when you talk about ketogenic diets, there's at least four different types of diets. So when somebody talks about, well, I want to be on a, high protein, low carb diet, there requires several questions because there are several different types of ketogenic diets. There's classic, there's the modified Atkins, the medium chain triglyceride ketogenic diet, the low glycemic index diet. You really have to figure out what type of diet that person is talking about. A diet that the protein content can be anywhere from 0.8 grams per kilogram of body weight, which is appropriate, up to 1 to 1.5 grams per pound, which is way too much. And a lot of times these diets have less than 50 grams of carbohydrate a day, which is far too little for a person with PKD. It really should be more around 200 grams of carbohydrate a day. And then generally these diets have no fat or calorie restriction. The positives for a ketogenic diet are it is beneficial for some conditions, and that's generally seizures or seizure disorders. And initially, people do lose quite a bit of weight, but that weight stabilizes over a year. Initially, they can be more satisfying, but generally, what happens is people can develop what's known as the keto flu. And that's when you are in ketoacidosis, you may not feel good. You may have symptoms of what are like the flu. The lipid profiles are initially favorable in that LDL's lower, HDL's increase, and triglycerides lower. The negatives about ketogenic diets are that it is expensive because it is a animal-based diet. A lot of people may have accessibility issues. It can lead to ketoacidosis. Obviously, that's the point. It can lead to kidney stones, which are, we think, a possible problem for PKD, and it is outright contraindicated in a PK deficiency. And as I mentioned, there is the keto flu, and that makes it hard to stick to long term. The expense and the keto flu. I don't know a lot of people who have been able to stick to it long term, and it's loaded with iron. And then also the final negative for it is it may disturb the gut biome. So at this time, I would not recommend the ketogenic diet for PK deficiency, or if there is an interest in that diet, to look at maybe some of the modified diets, perhaps the low glycemic index treatment. I would also include fasting diets and very low calorie diets as diets for people with PKD not to include, because we need that steady flow of carbohydrates to convert to glucose for the glycolytic cycle. If, however, you have religious beliefs that require you to fast, then I think a 24-hour fast is perfectly acceptable. So, in conclusion, the U.S. dietary guidelines are My Pyramid, Mediterranean Diet Plan, the Indo-Mediterranean Diet Plan, the Japanese dietary plan, the plant-based plan, DASH, and Mind Diet are really good diets. Thank you.
Thank you, Tamara. And that is really fascinating. And I would not believe there were so many dietary options out there. Clearly, I guess the difficulty is with people with PK deficiency is some of us have liver disease or heart failure, and therefore different diet plans. And I've certainly had very conflicting advice versus my diabetes or my liver failure. And some say have lots of carbohydrates at night to keep you going. And obviously the diabetes team would say don't do that at all because of your blood sugars. So that is really useful advice. And thank you. That I'm, yes, intrigued by all this, and I'm sure we'll have further conversation at another point. Just a reminder, I've put a note in the comments to say that if anybody has any questions, please pop them in the Q&A box at the bottom of your screen. There's none there at the moment. We will take them in the order they arrive. So if you pop a question in, you will guarantee to have it asked. So we move now to Dr. Rachael Grace, who is a pediatric hematologist at the Dana-Farber Boston Children's Cancer Center and Blood Disorders Center, and also an associate professor at Harvard Medical School in Boston, Massachusetts. She's the medical director of the Hematology Clinical Research Program, and I know from experience of working alongside Dr. Grace on various bits of research, particularly around the peak registry, that she spends so much time on research and supporting our community in trying to understand what is wrong with us and how to move forward to better therapies over and above supportive therapy. Now, Dr. Grace is going to talk to us today about the diagnosis and management of PK deficiency. Dr. Grace, we are really pleased to have you with us today, and we're looking forward to hearing what you have to say. Thank you.
Great. Thanks so much. Can you see my slides okay?
We can, yes.
Great. Well, thank you so much for that introduction, and thank you to the organizers for inviting me to be a part of this meeting. I'm looking forward to spending the next little bit talking with you about the diagnosis and management of pyruvate kinase deficiency. Before I get started, these are my disclosures. To provide you with an overview of today's combined community and clinician session, I'll briefly discuss the diagnostic testing for pyruvate kinase deficiency, and then I'll spend the majority of our time focused on the management of PK deficiency, highlighting the monitoring and management of chronic complications, the standard management of anemia, and then targeted and advanced therapy. And much of what I'll be focusing on today comes from the international expert guidelines, which were published in Lancet Hematology last year. And these guidelines can also be found on the web link that's at the bottom of this slide, pkdguidelines.org. So let's first turn our attention to the diagnosis of pyruvate kinase deficiency. When we talk about the diagnostic testing, it's important to have an understanding of what happens to red cells in the setting of pyruvate kinase deficiency. PK deficiency is caused by genetic mutations in the PKLR gene, and there are over 350 mutations that have been previously described, and most people with pyruvate kinase deficiency have 2 different mutations, and so are compound heterozygous. With a deficiency in pyruvate kinase, there's a decrease in the conversion of sugar or glucose into energy or ATP. And with a deficiency in red cell energy, the red cell can't maintain its shape and breaks apart in a process that's called hemolysis. This leads to the lab and clinical manifestations of pyruvate kinase deficiency, including the low hemoglobin or anemia, an elevated indirect bilirubin level, which causes jaundice and scleral icterus, and leads to a compensatory increase in red cell production in the form of reticulocytes. Pyruvate kinase deficiency is autosomal recessive, and this means that females and males are affected equally. Most commonly, two parents are carriers of one PKLR mutation. This means that they have one mutation, but they don't have any red cell findings or red cell breakdown. There's a 1 in 4 chance of having a child with pyruvate kinase deficiency if each parent is a carrier, and that's what's shown in the figure here. Given the recommendations for specific monitoring tests and the option of targeted therapy, making a diagnosis of pyruvate kinase deficiency is key for optimal management. These lists the recommendations that are in the guidelines around the diagnosis of pyruvate kinase deficiency, and if available, genetic testing is indicated in most people with pyruvate kinase deficiency. For initial testing, you can either send a pyruvate kinase red cell enzyme activity level or send genetic testing for that PKLR gene. If the initial test is red cell enzyme testing, then a confirmatory test should be to send the PKLR genetic testing. And that's because there are lots of reasons that the PK enzyme activity might be low, most commonly that someone might be a carrier for pyruvate kinase deficiency. If there's PKLR genetic testing that's sent first as the initial testing, but there's only one mutation, even though the person has red cell breakdown that looks like pyruvate kinase deficiency, or someone has a new mutation, which might be found in up to 20% of people, then pyruvate kinase red cell enzyme activity should be sent to support the diagnosis or confirm the diagnosis of pyruvate kinase deficiency. If you had testing a long time ago and you're not sure of what kind of testing you had, it's good to revisit that and look at these guidelines, especially in light of the new treatments that we're going to be talking about. So let's now focus on the monitoring and management of chronic complications. Symptoms and complications vary quite a bit among people with pyruvate kinase deficiency. Iron overload is a common complication at all ages, and it's under-recognized in people, especially who aren't regularly transfused or who have never been transfused. And it's important to monitor for iron overload because it's very manageable with iron chelators in most people. And if iron overload is untreated or inadequately treated, then damage can occur in the liver and in the heart and in hormone-producing organs. And some of that may not cause symptoms for quite a while until there's quite a bit of iron buildup. Guidelines are outlined here for pyruvate kinase deficiency, and these recommend screening with a ferritin test starting at age 3 or after 12 transfusions, which can occur in younger children. Ferritin-based monitoring frequency is customized to each individual and needs to be conducted at least once a year. For patients who have regular transfusions, the frequency might be every 1 to 3 months. But given that ferritin is what's called an acute phase reactant, it increases in the setting of inflammation, the result on a single test needs to be cautiously interpreted because it may be elevated in the setting of an infection, for example, and a repeat assessment should be done before proceeding with an MRI based on a single result. An MRI for liver assessment, so an MRI, as an example of that, would be a T2 star MRI, it's called. Looking for liver iron content should be done if the ferritin is over 500 nanograms per milliliter, regardless of whether someone's received transfusions in the past. If the MRI shows a liver iron concentration that's greater than 7 milligrams per gram dry weight, then a cardiac MRI is recommended. And so the guidelines recommend different testing based on either the ferritin or MRI assessment of iron. And you might wonder, why are different tests recommended? This figure here shows the correlation between the liver iron concentration, which is shown here on the y-axis, and the ferritin shown here on the x-axis. And you can see on a population, on this whole group of people with pyruvate kinase deficiency, there is a good correlation between the ferritin and the liver iron assessment. But on an individual basis, the ferritin doesn't always indicate iron overload that's seen on the MRI. And so, for example, if we used a cutoff of a ferritin of 1,000, we would miss all these people in red who have an elevated liver iron concentration on MRI because we might not do an MRI if we use that cutoff of 1,000. So instead, the recommendation is 500, but you can see even this isn't perfect. So it's helpful to have that MRI for an individual person to see how the ferritin correlates with the liver iron concentration. It's critical to diagnose and treat iron overload, and iron chelation is recommended in children who are 2 and older who have an elevated liver iron concentration of greater than 5 milligrams per dry weight with liver. And that's, again, regardless of transfusion status. There may be reasons that the MRI isn't available to you. It does require sedation in younger children. And so guidelines are also here for those who can't have an MRI. And so if a child is 2 years and older and has received more than 12 transfusions, same with an adult as well, and has a ferritin greater than 1,000, then iron chelation should be initiated. As was mentioned in the previous talk, bone health is an important issue in people with hemolytic anemias in general, and particularly in pyruvate kinase deficiency, and was previously under-recognized. Vitamin D monitoring is recommended starting at age 1, and bone density scans called DEXA scans are recommended starting at the age of 18 years. Hormone monitoring through blood work is recommended in those with iron overload, which you can see here is a ferritin over 1,000 or a liver iron concentration over 5. And for people who have osteopenia or osteoporosis, low bone density, or lab abnormalities of their hormones, they should be referred to an endocrinologist. It was not recognized initially or for a long time that bone health was an issue for people with pyruvate kinase deficiency. And the awareness of this really came about from a clinical trial of adults with pyruvate kinase deficiency, where bone density scans were obtained at baseline as part of this clinical trial and then followed over time because of a concern about an off-target effect of the drug. But in this group of 159 people with adults with pyruvate kinase deficiency, 3/4 had osteopenia or osteoporosis, and the average age was only 34 years. This is showing that this was a real problem in people who have pyruvate kinase deficiency. This figure shows the DEXA scan at the spine in particular, and shows that 85% of adults having this imaging had low bone density on their spinal imaging. So we're going to move now to the standard management of anemia approaches. There are multiple supportive strategies that are important in PK deficiency, and we know from registry studies that the supportive treatment approaches vary among patients and also vary among providers and countries. And so I'll recognize this as we're talking about these more standard approaches or supportive approaches. Splenectomy is a potential surgical treatment for pyruvate kinase deficiency. The spleen is a site for red cell injury and clearance and leads to hemolysis of the youngest red cells, the reticulocytes in particular. It's only partially effective in pyruvate kinase deficiency at best, and so careful consideration is needed in deciding about who should have this treatment. Guidelines recommend a discussion of individualized risks and benefits. Splenectomy comes with the lifelong risk of a serious bacterial infection because the importance of the spleen in those protecting from those infections, and also with a risk of thrombosis of blood clots. In addition, people with pyruvate kinase deficiency, as I mentioned, generally have an elevated indirect bilirubin level from that red cell breakdown, and this can lead to a type of gallstone called pigmented gallstones. This is especially so in people who also have a common genetic variant leading to what's called Gilbert syndrome, which often leads to a much higher bilirubin than expected for the red cell breakdown. Because red cell breakdown continues even after somebody's spleen is removed, an ultrasound should be done prior to splenectomy to look for gallstones, but removal of the gallbladder or cholecystectomy should be considered even in the absence of gallstones. And this comes from registry data where over 100 people with splenectomy for pyruvate kinase deficiency were in the registry and hadn't had a cholecystectomy prior to the splenectomy, and half of those people required the cholecystectomy after the splenectomy, so to try to avoid that second surgery. What do we know about splenectomy as treatment for pyruvate kinase deficiency? In the registry, 60% of people had had a splenectomy prior to enrollment. The average age was around 5 years. The average hemoglobin after the procedure was 8.8 grams per deciliter. So you can see that it was only partially effective at best because that's still quite anemic. And the average increase in hemoglobin was about 1.5 grams per deciliter. In terms of other splenectomy outcomes, there was a 90% reduction in the need for regular transfusions. So about 10% of people still needed transfusions after splenectomy on a regular basis. The rate of blood clots after splenectomy was 11%, and the rate of serious infection was 7%. So those numbers are not insignificant. Predictors of response to splenectomy demonstrated a correlation with the genotype. So again, pointing to that helpful genetic testing that if people had at least one missense PKLR mutation, they were more likely to have benefit from splenectomy. And those with a higher hemoglobin and a lower bilirubin level also were more likely to have a better response to splenectomy. So when should splenectomy be considered? In the setting of new treatment options, which we're going to talk about in a minute, this has become even more challenging in terms of that individualized decision-making. If there's an opportunity to try a pyruvate kinase activator before splenectomy, this should definitely be considered since the splenectomy is irreversible and stopping an oral treatment is relatively easy. If chelation and transfusions are well tolerated and someone is overall doing well, splenectomy may not be warranted even in the setting of those transfusions. And the considerations around the splenectomy are those that were on the prior slide around the recommendation, including the frequency of transfusions, symptoms related to anemia, being in the age range where we feel it's safest, and then pursuing full splenectomy, not partial, which is not effective. And after splenectomy care is incredibly important. Just for those of you listening who've had your spleens surgically removed, just to remember that prophylactic antibiotics can be considered in a preventative way. There's a need for urgent fever management. A fever over 101.5 Fahrenheit should lead to an emergency room visit within an hour, a blood culture, and IV antibiotics. That everyone should stay up to date on their immunizations and immunization boosters, which are different for people without a spleen. And then just to recall the risk of thrombosis or clots. Transfusions are quite variable between individuals with pyruvate kinase deficiency, and more than half will have been transfused on a regular basis. The transfusion strategy is quite variable because it's individualized. And that's one of the most important part of the guidelines here, which is this third bullet, which the recommendation is for transfusions based on symptoms and complications in people with pyruvate kinase deficiency rather than a universal hemoglobin transfusion threshold. And this is really quite different than other hemoglobin or red cell disorders, including thalassemia, which people are often much more familiar with. For this last part of the session, I'll focus now on targeted and advanced therapies. Mitapivat is an oral pyruvate kinase activator that's generally taken twice daily and binds to both healthy red cell pyruvate kinase and red cells with mutant pyruvate kinase. The figure here shows on the left what happens with red cells with pyruvate kinase deficiency, as I showed earlier in this talk. And the figure on the right shows that mitapivat can bind to the pyruvate kinase protein and can stabilize and activate the enzyme and thereby lead to an increase in red cell energy or ATP. The recommendations in the guideline really follow from clinical trials that were conducted in adults with pyruvate kinase deficiency. And so the first recommendation around mitapivat is to start this medication in adults with pyruvate kinase deficiency who are anemic, who do not receive regular transfusions, and who have at least one PKLR missense mutation, regardless of their splenectomy status, with the goal of improving hemoglobin and quality of life. And I'm going to talk more about that in a minute. The second recommendation is around adults who receive regular transfusions to start mitapivat if they have at least one missense mutation and regardless, again, of their splenectomy status, with the goal of reducing transfusions and improving quality of life. And a recommendation that adults who receive regular transfusions and have not undergone splenectomy should try mitapivat before thinking about splenectomy, which I mentioned already. So the data to support these recommendations, again, comes from clinical trials. This was from the adult trial, a trial of adults with pyruvate kinase deficiency who were not regularly transfused. And in those adults taking mitapivat twice a day, 40% had a hemoglobin response, which was defined in this trial as an increase of a hemoglobin of at least 1.5 grams per deciliter over at least 2 time points. And these responses were sustained with continued treatment. This graph shows on the y-axis the change in hemoglobin, and the x-axis is time, and purple are the people who take mitapivat, and you can see that increase in hemoglobin, which was sustained over time. The gray shows people who were taking a placebo, so not on the study drug, which you can see no change in the hemoglobin, and then an increase when they were able to switch to taking the drug, and their hemoglobin that was again sustained over time. I highlight here pediatric data that was not available at the time that the guidelines were created because the clinical trial results are just coming out over this last year, but this showed very similar results with a 31.6% rate of hemoglobin response. So that's quite similar to the adult data, and 0% in the placebo arm, again, quite similar to the adults. There was also a trial of mitapivat in adults who are regularly transfused, and there was a 33% rate of transfusion reduction response, so at least a 1/3 reduction in transfusion, and that was maintained over the study period. Pediatric data were quite similar, with 28% met this criteria compared to that 33%. And 22% in the adult trial became transfusion-free, meaning they didn't need any transfusions after starting mitapivat, which was sustained over a long period of time. And that's similar to what was seen in the pediatric trial, also with 18.8% becoming transfusion-free. In addition, improvements were seen in the report of quality of life using multiple measures, including in this figure, the PKDD, so looking at the impact of pyruvate kinase deficiency on everyday life. Blue shows you the people who got the mitapivat with a decrease in their scores, decreases in improvement. The people in placebo who didn't get the drug didn't have a change until they switched over, and then they also had a decrease, and that was sustained over time, meaning the quality of life improvement continues. There's also guidelines about when to stop mitapivat, which is really important for people thinking, well, how long am I going to need to be on this? How will I know if it's working? The recommendation is for people who don't receive regular transfusions to take the drug at the maximum dose, the optimal dose, for at least 3 months before saying it's not effective. For people who do receive transfusions, looking to see if they've had at least a 1/3 reduction in transfusions, but also looking at improvement in iron, looking at patient reported outcomes or how people feel every day and other key parameters. And with a recommendation that looking at how the drug is affecting somebody's everyday quality of life should be looked at as a determining factor for success, in addition to looking at lab markers. What to do if mitapivat isn't effective for you? It's so frustrating and disappointing for the people where that's the case, which is actually the majority of people if you look at those clinical trial numbers. And so the recommendation is to consider alternative approaches, including other clinical trials, for example, gene therapy or other PK activators. It's not open for people with pyruvate kinase deficiency right now, but maybe in the future, and thinking about other options like stem cell transplant. There's very little data about stem cell transplant and pyruvate kinase deficiency, which makes it difficult to know how to consider this option. This is the biggest population that's been reported. It's only 16 people from all over the globe who are all managed differently with different types of donors and conditioning and prevention of graft versus host disease. But there was a high rate of graft versus host disease where the stem cells fight against the body, and a higher mortality rate for sure than is desirable. This figure shows that the safety is better for people younger than 10 than older than 10, but with this limited data, the decision-making about this is very challenging. Gene therapy has also been explored, and there are phase 1 data for lentiviral-mediated gene therapy approaches using myeloablative conditioning. 2 adults have been described. That's what's shown here on the left, with a robust response in hemoglobin of 6 to 7 grams per deciliter, improvement in hemolytic markers, improvement in quality of life, with long-term follow-up of about 3 years. Early data have been reported for adolescents as well. That's shown here on the right, one with an effect like the adults, one with a more partial effect, with longer-term follow-up needed. This is very promising. There was going to be a phase 2 trial that's currently on hold, as the company has refocused on other efforts for right now that was going to conduct the trial. And with that, I want to leave you with that data from registries and clinical trials have really helped to build these monitoring and management guidelines. And I want to state my appreciation for all of the people maybe participating in this conference who participate in these registries and trials, because this really helps to improve the care for people with pyruvate kinase deficiency. And the goal and the hope is that with new approaches to diagnosis and monitoring and treatment, that the care really will improve for people with pyruvate kinase deficiency. And thank you for your attention, and look forward to these questions.
Wow. Thank you, Dr. Grace. There is a lot of information there, and I'm sure both yours and Dr. Schryver's slides will be available afterwards, and I think also a recording. I think what is fascinating is to hear that actually PK deficiency is different from other anemias, and having been part of the guideline authoring group along with Dr. Schryver, we learned a lot along that way, and I think it's really helping us advocate for people now. And we need to find some way of making sure these guidelines are just keep being fed to clinicians across the world. We have a number of questions. We have about just under it's over 10 minutes for questions. So I have a question for Dr. Schryver to start with. You said you wouldn't recommend a ketogenic diet for PKD patients. What about sickle patients in general? Is it a good diet plan for better health?
I'm not an expert on sickle cell disease. There is an expert that is located. I could pass on her name. She's located in England. I don't believe that she would recommend that as an ideal diet. Um, I don't know enough about. I think I think that I would need to know more about the status of the person that has the sickle cell disease to know. I My inclination is to say no, but to say that since I'm not an expert on sickle cell, that I would probably refer them to a dietitian that I know who is an expert on sickle cell.
Perfect, thank you. And then a question to Dr. Grace is, since pediatric trials of Pyruvate have been conducted for PK deficiency, how can children who are not enrolled in the trials access this treatment?
It's an excellent question. There's a different answer to that question based on where in the globe you are. Although the trial results are just coming out, so they've been presented at, the trial for children who are regularly transfused was presented at a hematology conference over the summer, and data from the children who are not being transfused being presented at a hematology meeting in December. And the hope is that that information will help get the drug approved for younger people, that it's currently only approved for people 18 and older. And so it's a challenging window of time to be in where the clinical trials aren't open and the drug's not yet approved. And globally, sometimes even when the drug gets approved, it's not approved in the country that people live in or accessible. In the state that we're currently in, before any approvals where trial data is available, there is an expanded access program in the United States, so that if you or your provider are in the U.S., there you can apply for approval through the FDA for a single patient IND and get access to the drug in this way, which means it is available in the U.S. Through that path. Outside of the U.S., I would encourage you to look on the Agios, that's the company that makes the drug, to look on their website for information about who to contact about how to access the drug outside of the US, because that expanded access program is only in the US.
Thank you. And a question then to Dr. Schryver again is, how do you get appropriate nourishment when you often don't have the appetite to eat because you're in pain, you're hospitalized, or chronic fatigue that we with sort of chronic anemia suffer from?
That's a really good question. I think that's when you are feeling better is the time to to do some planning, so that it's an opportunity to visit a registered dietitian. If you don't have that access, I think it's the time, like I said, when you're feeling better, to do some planning about how you can get some quick, easy snacks and meals that are nutrient dense. So by nutrient dense, I would say that they're high in calories, but also high in valuable nutrients. And it actually is a great idea for something that we could put together and distribute. But foods like nuts and yogurts and easy access foods that we could put together a list of foods that are just very nutrient dense for people to carry with them or to keep with them, so that when they're not, it's a very common feeling to not feel good. To meal preparation is almost impossible. And I have experienced that in my life as a patient. And so it's just quick nutrient dense foods. It's hard, especially if you're somebody who's responsible for providing meals for the family to also have those quick, easy, nutrient-dense meals. And I think that's something that we could provide as an organization is some ideas for that.
Thank you very much. Can I just a shout out to people who are adding in the comments that they have PKD, haven't met anybody before. I'm sure I'm allowed to advertise the fact that we have a Pyruvate Kinase Deficiency International Alliance Facebook group, and also have a look at pkdia.org, our website. And please hook up with us, get in touch, and we are always happy to build in our community and offer whatever support we can. Very quickly then, before I go back to Dr. Grace with a question, someone's asking about creatine supplements to support PKD. They were once advised by the hematologist to have it to help with low energy. What are your thoughts on that, please, Dr. Schryver?
The question was around creatine.
Creatine, yes. Is that a good idea in PK deficiency?
I have not. I would, if a doctor has recommended it, I would be curious as to why. I don't know that there is any benefit that I'm aware of to creatine. Um, I would be curious as to why the doctor recommended, and I would be open to further exploring it. But to my knowledge, there is in all the supplements and the the foods that we reviewed for the book, we did not come across creatine as a benefit for PKD.
Thank you.
But again, open to looking at it.
Yeah, we'll always have a look, but at the moment you've not heard it as an option. Okay, and Dr. Grace, one question is, what are the secondary effects of Mitivipat, and what about someone who has liver cirrhosis? Are they able to access, if they can access a drug, is it safe for them and potentially beneficial?
I did fail to mention potential side effects of mitapivat as I was talking about, the downsides to splenectomy, for example. And mitapivat is generally well tolerated, but there are, relatively more common, potentially reported side effects like headache, nausea, insomnia, facial flushing. These things are, when they happen, often when someone first starts on the drug and then seem to get better over a relatively short period of time. And there are things that are less common, but are important to monitor for. So one is that if you are on the drug and it is working well and you abruptly stop it, then you can have really significant red cell breakdown. So it's important not to miss doses, especially if it's effective for you. Another is that the cholesterol levels, triglycerides, need to be monitored for people who are on the drug, because that has been seen rarely in some people on it. And then the liver tests actually do need to be monitored in people on the drug as well. And that there have been people who are on the drug for another red cell problem, thalassemia, in clinical trials, who have had elevation in their liver tests taking it. That hasn't happened for someone with pyruvate kinase deficiency, but because of that, liver tests are monitored. It is hepatically cleared in the liver, and so liver function might impact the amount of drug your body sees. And so I think it would be needed to be carefully prescribed depending on your liver function. And so that would be important to discuss with your hematologist. There are 3 dosing levels that are used. And so it may be that that's a way to approach this, is seeing how it is with a very low dose before moving forward and how your body's metabolizing it. And so I would encourage you to talk with your provider about that.
Thank you very much indeed. Schryver, one last question, and is people are asking about if they want to gain or lose weight. We put questions around children as well as adults. So if they have PK deficiency, where should they go in terms of what diet to think about, and actually how to safely lose weight without the side effects of not having enough energy to supply and keep your red cells as healthy as possible?
Yeah, so again, I'm going to recommend that they see a registered dietitian, but you can take any of these dietary plans and break them down into calorie levels, which is where I would recommend having a visit with a dietitian. So any of these dietary plans, you can prescribe calorie levels to them. And so you sort of have to figure out how many calories are you eating right now, and then do a reduction of, whatever your long-term goal is. Maybe it's a reduction of 200 calories a day. With children, I would not recommend putting your child on a diet. I would recommend that again, you go see a registered dietitian, and really the approach be more like the family goes on a lifestyle change, and that the child grows into healthy habits and the family grows into healthy habits. So I don't recommend putting children on diets. I mean, there are extreme cases, and that really needs to go to a specialist. But really, it's about just adopting healthy lifestyles, and that include eating healthy behaviors, activity, that sort of thing, because we don't want to start that rat race of, you know, where you're placing a child on a diet because they're not good enough. You just don't want to start that mental battle in a child. It can set them up for long-term mental health problems, as well as failure and eating disorders. So it really needs to be a family affair, that the family is changing their lifestyle.
Thank you very much. Thank you, Dr. Schryver and Dr. Grace, for your time today and your really interesting talks. And there is so much to absorb there, and it makes it really obvious how complicated PK deficiency and, in fact, other red cell disorders are, and all different factors that can happen. And I think one thing that struck me, and I've always thought this as somebody with PK deficiency and Gilbert syndrome, is how jolly unfair that is. So the one thing that, your red cells are breaking up, driving you to be yellow, and as a sort of a young child and teenager, and then you find out actually you've got another enzyme issue that means that the very thing that's making you yellow, you can't clear from your body. And I just think somebody somewhere was having a horrible joke with us on that one. But it's been fascinating, and I'm sure if people have questions, they can get in touch with Gansu directly. I think we've answered all the questions today, but if you've got other comments or thoughts, then please get in touch with Gansu. I'm sure they'll pass them on to our excellent speakers. And I see rounds of applause happening online, so we're really grateful for your time today as people have been involved and watching. And please enjoy the rest of the conference today and tomorrow. And as you can see, we've got a 15-minute break now, and then we'll come back for the next session. So thank you both again, and we'll talk to you very soon. Thank you. Goodbye.
Thank you, everyone. Thank you, Carl. Thank you, Dr. Schryver. Thank you, Dr. Grace. That was a wonderful presentation. I learned a lot about PKD today that I did not know. So thank you so much for your insightful knowledge. So yeah, we do have a 15-minute break now before our last session of day one of the Congress. So if you have some time, grab some coffee, stretch your legs, and then please fill out this survey that we have here in the QR code to give us some of your feedback and information. Yeah. So
Thank you.
we'll see you all at the last session. And thank you once again, panelists and moderators.
Thank you.
Thank you.
Thank you, everybody. Take care of yourselves.